Hi, everyone. Welcome. I'm Angela Love-Zaranka, Program Director at Lactation Education Resources.
And I am Sekeita Lewis-Johnson, accredited program provider, director. I'm sorry, I should have said director before that. So welcome and thank you for joining us this afternoon or morning or evening or night.
Whatever time it is where you're listening, we do know we have people from all over the world. Just a brief introduction about myself. I have been board certified for over 25 years. I have been working in community support of breastfeeding for 30 years. I have served as well on the IBLCE board of directors, including the exam review and the exam creation committees. Sekeita?
Yes, thanks, Angela. I bring you experience, about 25 years as a nurse, 15 years as a certified lactation consultant, board certified, and also as a nurse educator. I actually have taught clinical and also in hospital settings as well as inpatient settings. So welcome.
So between the two of us, you've probably got about, 50 plus years of experience. And so we're going to take some time today to answer your questions, but to provide you with just a little bit of a framework, sort of an outline of a review of what you may want to review before you take the IBLCE exam. So we're going to be reviewing, Sekeita and I will be reviewing a few key concepts in different areas of the detailed content outline. So the topics that we're going to present today are based on the candidate's performance in the past, their past performance, and we chose the ones where people usually will have the most challenge. And so we will also, during this webinar, we're going to have a chance for you to test your skills. We've got 14 multiple choice questions that we'll be asking in a bit and give you an opportunity to answer them. And then finally, we're going to review a few test taking strategies and emphasize what you can do for yourself before, during, and after the exam. So if you would like to ask questions, asking questions in the GoToWebinar platform is easy. If you're on a desktop, this is where you will find the question bar. That blue arrow is showing you. And if you're on a mobile device, they can be found along the bottom bar of the app as a question mark. Now we have Julie on the call today, as well as Jeanette. They are both IBCLCs and have taken the exam recently, and they are part of our fabulous customer support as well as our communications team. Jill is also on the call today from our tech team. So if you have any tech questions, please type them or any comments that you have into that question box. Please do not photograph or record this information with a camera, phone, or other equipment. We are recording it, and you'll be able to watch the session as many times as you'd like. A few of the questions which are answered during the session will be answered by Julie and Jeanette, as they are both IBCLCs. They will flag other questions for Sekeita and I to answer during the session, even if that means that the session goes just a little bit long. So let's begin with medications. Sekeita?
Thank you, Angela. All right, so I'm going to start with medications because sometimes folks think medications sometimes is the hardest thing, but I want you to think about the exam as more practice oriented. How do you apply the knowledge to a clinical situation? So remember that the amount of medications that's excreted into breast milk or human milk depends on many factors. All right, so we're going to talk about a few of those, and we're going to hopefully ease your mind with how to think about medications. So the milk to plasma ratio is useful because it evaluates the relative concentration of the medication in the plasma compared to in the milk. All right, so high ratios, if there's a medication that has a high ratio, it'll usually enter into the milk more easily. So that's straightforward. The relative infant dose is a very important clinical parameter to determine safety. It usually is expressed as a percentage of the lactating person's dose, so percentage. According to HAL, medications with a relative dose less than 10% is considered relatively safe for a full-term infant. Now, I want you to just really remember full-term infant. So we don't want to just think, okay, one size fit all, 10% is good for everyone. So a relative infant dose greater than 10% for a full-term infant should be a cause for caution and further assessment of the situation, okay? When we think about oral bioavailability, I always have to slow down with that word. This refers to the ability of the drug to reach the circulation after it's ingested. Drugs with low oral bioavailability are generally poorly absorbed. What is wrong with my talking today? In the infant's GI tract and destroyed by the gut, or it's taken up by the liver before it enters into the infant's circulatory system. So, one of the other key points of medications is that medications enter the milk compartment only from the lactating person's blood, all right? And then there's the colostral phase where, we say, drugs usually enter into breast milk or human milk at small amounts. During the colostrum phase, medications transfer more easily into the milk compartments, and that's due to the large gaps among the alveolar cells. So medications transfer into milk easily. However, the total dose transfer to an infant is low because during the colostrum phase, infants are not getting a ton of volume. So keep that in mind, all right? All right, so I just said that most drugs enter at clinically insignificant levels. Now, there is one thing that we all have to do as clinicians, and that's always to determine the level, the drug levels in milk, the relative infant dose, and the lactation risk category. And there are ways to do that. Just know that, based on, for instance, HAL classifies these drugs as L1 through L5, with L1 being the safest, L5 being hazardous, okay? Other things you want to be cautious of as a practitioner, and also to think about for the test, you want to be cautious of high vitamin doses. And you also want to think about avoiding, or not you, but someone who is providing breastfeeding or human milk, avoid high doses of sedative drugs, narcotics, radioactive agents, chemotherapy, or high doses of iodine. So in a nutshell, next slide, please. In a nutshell, when you think about if the drug can transfer into milk, you want to think about drugs may transfer if they have high concentrations in the maternal plasma, or drugs who have lower molecular weights, like less than 800 Daltons, low protein binding, and drugs that pass into the brain easily. So when you sum up a lot of the things that I've talked about on the slide, I guess saying it in reverse, you want to choose medications that have shorter half-lives, high protein binding, low oral bioavailability, or high molecular weights. And I did that, so I'm going to stop and pause before we go to the next slide, because sometimes people get confused on this slide. But I did this because some people think about certain topics in different ways, and so it helps to kind of format it in a way of the both sides of the coin. All right, antibiotics. So antibiotics are commonly prescribed. They're commonly prescribed for almost everyone, but sometimes in the after the birth, there's sometimes antibiotics during birth. There's sometimes antibiotics given, and then even later on into the nursing journey. So medications include antibiotics. People will have a lot of questions about the safety with breastfeeding because it is so common. As a general rule, antibiotics are compatible with breastfeeding. Cipro is one of the medications that's an L3, and it has been associated with GI problems. The really biggest problems when we talk about, or the biggest concern when we talk about antibiotics, are the changes that can occur in the gut flora and the development of antibiotic resistance. So you don't really have to know like the drug names per se. So don't remember this whole chart or the L category. This is there to just give you the notion of safety as it relates to antibiotics. If you're not familiar with many drugs, it might help you to know that most antibiotics end with IN, such as ampicillin, and that's true for many, but not all. Antifungals, they're another class of drugs that's commonly prescribed. You'll see this prescribed primarily for like fungal infections, such as thrush, which is an oral infection, or other types of fungal infections. It's important about antifungals as it relates to thrush. If the infant is being treated for thrush, the parent should also be treated simultaneously. And that's because the infection can pass back and forth easily, and sometimes it's hard to get rid of. Topical antifungals, such as like nystatin and miconazole, are used to treat yeast and are also considered safe as long as minimal amounts are applied to limit the absorption. All right. Next slide, please. All right. So now we move to pain. This is probably the second most common. Well, I would say first, because after almost every delivery, there is some amount of analgesic that patients or clients will get. So they're pain medicines, all right? This class of medication, this class of drugs, I should say, have various compounds that make some of them incompatible with providing human milk. So let's look at Tylenol. When you look at Tylenol, Tylenol is an L1, which is compatible with providing human milk. However, if you combine the Tylenol with codeine, it's potentially hazardous because codeine is an L4. So when I say L4, what I mean is, according to HEL, the L4 is a classification that indicates that a medication is possibly hazardous. Now, as it relates to codeine, there are some individuals that have a genetic trait that makes them rapid metabolizers of codeine. So the FDA and numerous drug advisory groups have recommended that codeine no longer be used during lactation. So other medications you'll notice Motrin, which is an L1. You'll notice aspirin, which is an L2. Or I should say, however, it is not safe to use when the infant is sick or have a fever because of its association with Reye's syndrome. All right, and then the last thing I'm going to note really on this slide is opioids. So I'm going to talk about morphine. It's a potent drug, and it's classified as an L3. It's often used, though, in delivery. Sometimes it's used in the spinal cavity or for postpartum surgical pain management. And it appears to be safe for a limited use. So when we think about a medication like an opioid, remember that the compatibility of these medications listed are only if they are being used as prescribed. So being used as prescribed. All right. Anticonvulsants or anti-seizures. The bigger thing to pay attention to this is there is one on this slide that's an L4, which is Depakote, okay? The other thing I want you to notice is that magnesium sulfate is used commonly in preeclampsia. It's used to while someone is laboring, and sometimes for preeclampsia postpartum. In saying that, just know that some of the concerns for infants is that the infant can be sleepy, irritable, or sometimes have poor feeding, but it's still classified as an L1. Antidepressants. The 3 antidepressants that are listed on this table appear to be compatible with breastfeeding and human milk feeding. The one thing to note, we are seeing mental health and postpartum mood disorders. They are common, and it seems like they're on the rise. And so there's a spectrum of mood disorders, and there's also a spectrum of medications. This medication list is not all inclusive as a list. I just want you to be aware of that. These medications are listed as L2s and as limited data and probably compatible. So according to HEL, Zoloft seems to be the preferred medication. Keep in mind, there's been some controversy on the safety and compatibility profile of antidepressants. However, it's important that we always remember the risk-benefit ratio. All right. Infants should be monitored for sleepiness, poor feeding, low muscle tone, and agitation. All right, antihypertensives. Now, this is a busy slide. Again, don't try to remember all of these things. Just listen to what I'm about to say about this particular slide. These medications listed, as you can see, the L category, most of them seem to be compatible with breastfeeding or human milk. However, there is some asterisks at the very bottom of this slide. These 2 are what we call diuretics. They are, and you will hear other people say, like water pills. They're used for hypertension. They are L2, and Lasix is an L3. I'm sorry. The reason why there's an asterisk, because these 2 have the potential to reduce milk supply. Now, the other things you want to just always, when we think about the safety of medication, we always have to think about infant monitoring or its concern. So you want to monitor the infant or have the person monitor the infant for sleepiness, lethargy, pallor, or poor feeding. And then I'm going to move on to vaccines. Generally speaking, vaccines are safe while breast and chest feeding. Yellow fever, however, vaccine is not recommended, okay? Now, smallpox, I'm going to read from Lawrence and Lawrence, or I'm going to give you an excerpt, I should say, from Lawrence and Lawrence, which states, smallpox vaccination is inadvisable for the mother of any infant younger than 1 year of age, nursing or not. It's the personal contact, not the breastfeeding, that causes the risk. Therefore, no advantage exists to weaning if vaccination is necessary. This vaccination is not given routinely and is rarely indicated. So, I've concluded the portion on medications, but before we move to the next section, sometimes I have the tendency to talk real fast or move a little slower, or sometimes my words don't come out correctly. So I'm going to take any questions strictly about the medications, this review that you may have.
Great, Sekeita. So there was a question. Someone was asking if there should be, on the exam they're going to show the trade name and the generic name. Is it going to be one or is it going to be the other?
It usually is always the generic name of medications. So yeah, there are so many, like one drug can have 3 different names. Okay, so it's usually the generic.
Okay, great. And there doesn't seem to be anything else from a medications perspective. So I think we're good.
Awesome. Thank you. Angela, take it away.
Thanks so much, Sekeita. I appreciate it. So next we're going to go to breastfeeding beyond the first month. So in this, we're going to include some things where we're talking about, any sort of maternal concerns. We also we're also talking about nursing, extended nursing beyond those first few days, tandem nursing. as well as, infant growth and development. So there's a couple of different topics that we're going to cover in this section. When counseling clients with older nurslings, be mindful that the number of feeds and time at breast may fluctuate greatly. Babies might return to intense breastfeeding, chest feeding to adjust their parents' milk production as needed, which is sometimes referred to as growth spurts. They often occur around 2 to 3 weeks, 6 weeks, and then again at 3 to 4 months. This coincidentally corresponds with a shift in the maternal milk supply with a gradual transition from endocrine to autocrine control of milk production. Developmental milestones may increase night waking and nursing. These little ones seem to be too busy exploring their world to stop and to actually nurse. They may miss something if they do that. Therefore, they may wake up more frequently at night to receive the caloric intake they intrinsically know that they need. So it's something which is normal and it's okay. Latch and position techniques are considerably more flexible after the first few months. Note in the picture here that the baby is further away from the breast than when they were a newborn. Unless the parent is uncomfortable, there's no reason to suggest changing the position or the latch. Now, breast and nipple pain are two common challenges that some parents face while lactating. This is a portion of a 13-page algorithm developed by the University of North Carolina for breast and nipple pain. It's a very valuable resource and a good review prior to the exam for how to identify many of the causes of breast and nipple pain. In the handout, you will actually find, I believe, a link to this URL, to this website. Very helpful. So do make sure that you download the handout. It is in the same GoToWebinar interface, and right near the bottom it should say handout, so go ahead and you can download that. Mastitis is an infectious process in the breast that produces localized tenderness, redness, or discoloration of the skin and heat, together with systemic reactions of fever and malaise. Prospective studies estimate the incidence to be between 3 and 20%, depending on the definition and the length of follow-up postpartum. Technically, mastitis is an inflammation of the breast, which may or may not involve an infection. The problem can begin with engorgement, then non-infective mastitis, followed by infective mastitis to abscess if treatment is not introduced promptly. So symptoms will include a fever of 38.5 degrees centigrade or 101 degrees Fahrenheit, chills, headache, flu-like body aches and symptoms. The breast is painful and swollen. The breast area could be red or hot or tender to the touch. And the red blotches you may see, of course, on lighter skin tone folks. You may see streaks of color, either a bruised color or an inflammation, a red color on the breast tissue. So treatment for these things, of course, rest is number one. The parent can continue to feed or express on the affected side, and the milk can be provided to the baby. Cold compresses are helpful to reduce edema, and creative nursing positions can also be helpful. There is also breast movement, actually moving the breast, manipulating the breast, also known by Maya Bowman as breast gymnastics. And you want to support compliance with antibiotics if they are prescribed, and the use of analgesic or anti-inflammatory for discomfort, for fever, and for swelling. So in this image, you can see that it can be a little challenging to see the discoloration of the breast tissue. And I chose this intentionally because it is a little trickier to see. And so that's why it's important to take a thorough history, of course, when dealing with mastitis. Now, before everyone asks this question, will the mastitis, the new mastitis spectrum protocol, be on the IBLCE exam? The answer is we're not sure. We do know that the IBLCE exam is created months, if not a year or so, prior to the actual administration of the exam. So this year, I'm uncertain whether or not it will be included. So it's really helpful for you to be well versed in the new protocol. Staphylococcus aureus is cited by Dr. Ruth Lawrence in her book, Breastfeeding, A Guide to the Medical Profession, as a common cause of breast infection. Jimenez found that Staph aureus dominated the microbiome of mastitis sufferers. However, Staph aureus was found by other research in the milk of asymptomatic people. So in the case of recurrent mastitis, the causes could include delayed or inadequate treatment of the initial disease and continued milk stasis, or, as in the new mastitis protocol, hyperlactation. The diagnosis can be made with the culture of the milk and the infant nasopharynx or oropharynx. And treatment options and a thorough discussion can be found in the new mastitis spectrum protocol. Now, a small percentage, there, I made a note to myself in red to make sure that I addressed the new protocol. So a small percentage of breast infections do develop into abscess. Kinley et al. Reported the incidence to be about 5 or 10%, whereas Amir reported about 3% of women with mastitis developed an abscess. One theory is that healthcare providers are more educated in the prevention of abscess. Dr. Lawrence reports an increase in abscess rate when antibiotic treatment was delayed beyond 24 hours. An abscess is a localized collection of pus that forms from an infection that has no opening for drainage. The indications for an abscess are the same as mastitis, although symptoms may be less severe because the abscess is isolated from the rest of the breast. This picture demonstrates an obvious abscess. Occasionally, an abscess can occur in the absence of any systemic symptoms. And as I mentioned before, when antibiotic treatment was delayed beyond 24 hours, the abscess rate increased. Therefore, it's really important for the parent to continue with milk removal, to continue with the nursing, even with the abscess. If the abscess is located somewhere near the areolar tissue and/or the nipple tissue, then it may take a little creativity with potentially hand expression versus pumping, and or creativity with whether or not the baby can directly feed from the breast. So on the IBLCE exam, as opposed to being asked, you may be asked, for example, what the incidence is of breast abscess. That is a possibility. However, chances are it's going to be more on the application of knowledge as opposed to rote memorization and recall. So nursing through pregnancy is something which has happened and does continue to happen every single day. It's important to explore the parents' feelings about continuing breastfeeding if they find out that they are pregnant while they're nursing. Some women will note nipple and/or breast discomfort, and some will also mention that discomfort alerted them to the new pregnancy. Depending on the age and the nursing relationship, some nurslings may be reluctant to wean. Mature milk will change back to colostrum around 4 to 5 months into the pregnancy, which may change the taste and quantity of the milk. Oxytocin is released during nursing. However, the oxytocin is blocked by progesterone. There is no need to wean a nursing baby or child unless there is a true risk of preterm labor. There is limited data which shows an impact to the mother's nutritional status by continuing to nurse through pregnancy. Therefore, it is important that the parent be mindful of their diet. Now, some older babies and toddlers may stop during the pregnancy and then resume after the birth. So moving on then to tandem nursing. It's a term to describe breastfeeding of 2 or more children who are not born at the same time or are of different ages. It occurs when a mother nurses through her pregnancy, or if a previous child weaned during the pregnancy, they may be interested in resuming once the baby is born. Again, it's important to explore the parents' feelings about tandem nursing. As one of the pioneers in the lactation field, Shelley Marmette, once said, it takes the patience of Job to tandem nurse. If there's an issue with the infant's weight in the early days, make sure that the newborn is given priority at the breast or chest. Some mothers will dedicate one breast to the newborn and the other to the toddlers, and then switch the next day. Note here the way the older sibling has her arm around her new brother. Granted, it may be so everyone can fit on mom's lap, but it can also be a sign of affection. If a parent expresses a need to wean, again, explore their reasons why. Some families believe that weaning may increase the child's independence or help the child to sleep more at night, which may not be achieved through weaning. Gradual weaning works best for both the parent and the baby. It reduces the risk of severe breast pain and mastitis. In several texts on nursing a toddler, the first suggestion is don't offer the breast and don't refuse a child's request. A parent may want to eliminate a feeding every 2 to 4 days, and preferably not back-to-back feedings. It's important to continue as both the parent and the child can accommodate to the new routine. Hand express for comfort is needed. Change the daily routine for the child so that alternatives to nursing are offered and explored. Offer other foods or drinks before the regular nursing sessions. And breastfeed when asked is another idea, but for shorter periods of time. Okay, Sekeita, what do you think? Are there any questions here that we need to address?
I really think that you covered the mastitis question because there was some that popped up. So I think that our lovely IBCLCs have been answering them. And there's a few flagged that came in earlier, but we'll address those at the end. So I think, oh, wait, hold on.
I see one here, yes.
Discuss weaning. Does weaning actually help to spark a child's independence or help their sleep schedule, or is that a wives' tale?
Well, yes, it is quite the wives' tale, and it's quite a myth that people think that if only this baby will just wean, then, my life can get back to normal, so to speak. And so many parents do find that, sometimes weaning can help, but sometimes it doesn't. And sometimes I've heard where it can make things worse because the child, is unhappy, but more importantly, if weaning or is to create an independence in the child, there are other ways that may be helpful to do that. And so it's important to explore the cultural language and the cultural assumptions around that. I know parents where once they weaned, they lost a tool in their toolkit with how to manage a child who was unhappy in the middle of the night. Parenting is a 24/7 job. And so that was one thing that they noticed, is that now I can't nurse the baby and just go right back to sleep again. So you do want to make sure to explore the parents' reasons as far as the why. And of course, if they do want to wean, by all means, give them the tools that they need so they can be successful and healthy.
Yeah, great answer, Angela.
Thank you so much. Thank you, Sekeita. Okay, milk supply. So now we're going to jump into milk supply. So here you may have seen this image. This is a picture of the neuroendocrine reflex arc to remind us of the physiological mechanism of lactation. Milk synthesis is a complex interplay of the hypothalamic pituitary gonadal axis. Milk synthesis is related to the degree of breast fullness. Suckling or expression or other nipple stimulation stimulates prolactin secretion and the release of oxytocin. It's milk removal that enables milk secretion to continue. So this is a slide you may have seen in our anatomy and physiology, as well as in the relactation exam reviews. Now, according to Margaret Neville and Jane Morton, failed lactogenesis can be described as preglandular, glandular, or postglandular. An example of preglandular would be hormonal causes, such as retained placenta or lack of pituitary prolactin. Glandular causes might be surgical procedures, such as reduction mammoplasty or possibly insufficient mammary tissue. Postglandular would be any cause for ineffective or infrequent milk removal. Iatrogenic causes for lactation failure are those which are impacted by policies and procedures in the hospital or by healthcare providers, which can have a negative impact on milk production. A parent's perception of milk supply in the early hours and days after birth could be included here. It's a common perception that a sleeping or quiet baby is a happy baby. Therefore, parents may misinterpret a baby's lack of settling post-feed as a sign that the baby isn't, quote, getting enough and supplementing. Parents may interpret the normal newborn circadian rhythms as a sign that the baby is hungry in the middle of the night, and they may assume a lack of milk. But of course, we know that babies' circadian rhythms are opposite from their parents, especially in those early days and weeks. Postglandular, as I mentioned, would be any cause for ineffective or infrequent milk removal. So we're talking here about separation of the parent and the baby, pacifier use, and as mentioned in the previous slide, perceived insufficient milk by family or by staff. And so interventions which do require supplementation and milk supply, which is not simultaneously supported through hand expression or pumping, could be included in here as well. Structural issues, so breast or chest tissue anomalies, surgical interruptions in the breast or chest, a biopsy, reduction or augmentation, a chest tube placed in a baby, a preterm baby who then grows up and becomes a lactating person, or a thoracotomy prior to mammary development. Mammary hypoplasia, insufficient glandular tissue, or mammary asymmetry, which includes intramammary distance or the space between the breasts. All of these things are structural issues which could impact milk supply. So chronic illness such as hypo or hyperthyroidism, lupus, Parkinson's, diabetes, hypertension. Acute illness and birth-related complications, which include hemorrhage after birth, especially causing a large sudden drop in blood pressure and or requiring a blood transfusion. As a point of reference, 500 milliliters of blood loss is considered normal. Hemorrhage may cause damage to the pituitary, ranging from mild insult to major infarction. Sheehan syndrome is a severe hemorrhage and drop in blood pressure that may result in necrosis of the anterior pituitary. Hormonal issues such as irregular menses, infertility, PCOS, weight loss surgery, specifically gastric bypass surgery, which can impact the amount of nutrient absorption. Each one of these points on this slide could be reviewed in depth. If you have further questions about the specifics, please review your notes in the lessons or in the literature. So other factors for delayed lactogenesis 2, which is greater than 72 hours, include premature delivery, insulin-dependent diabetes mellitus or gestational diabetes, a metabolic status or health, which refers to an interesting study from Nams and Rivers, Donald and Huang, which describes 3 risk factors for delayed lactogenesis, which include a higher BMI, increased maternal age, and larger infant birth weight, which as known correlates with carbohydrate intolerance and systemic inflammation. And of course, fat-phobic bias and staff which are unaware of their bias and do not provide the support which a person requires in those early days. Also included other factors are hypertension, high levels of stress to the mother and the fetus during birth, prolonged stage 2 of labor, which is considered less than an hour, augmentation of labor with intravenous oxytocin, forceps or vacuum delivery, the timing of the first breast stimulation after delivery, significant edema of the extremities, and endocrine disturbances. There are complex interrelationships which exist among the various factors that may affect lactogenesis. Whether the delay of lactogenesis 2 is a maternal physiologic response due to delayed or ineffective suckling or a combination of factors has not yet been clearly identified. Early, frequent, and effective milk removal appears to be the most important factor in establishing normal lactation. I would argue that skin-to-skin and milk expression in those first hours after birth are really key factors to counter the possible risk factors. Those of you who work in a hospital setting can understand how that may be impeded with any of the above diagnoses. Now we also have to take a look, breast milk production is a 2-person or 3-person role. And so there is an infant's role on the impact of milk production. Any issues which could affect suckling and or sucking frequency may affect the initiation and calibration of milk production. The baby may not be capable of sufficient milk removal to initiate and maintain an adequate supply. Important factors include gestational age, premature infants, of course. Remember that late preterm infants may not suckle well enough for adequate milk removal. The infant's oral and facial anatomy. Any tongue mobility restriction can impact not only maternal discomfort, but also the ability to remove milk. palatal issues, obviously, including a partial or complete cleft of the hard or soft palate, but also includes a high palate, a bubble palate, or channel palate. And then any airway issues, which include laryngomalacia or tracheomalacia. Long term, the issues on the previous slide can impact the initiation and calibration of milk supply. Now, the following can impact the maintenance of milk production, such as infant hypotonia or hypertonia, birth trauma pain, such as shoulder dystocia, or the use of forceps or a vacuum, as with this infant on this slide, cardiac or respiratory issues, long-term impact, which can be long-term milk production can be impacted by the infant facial anomalies, the tongue, the palate, and sensory integration issues. Now, prenatal education can reduce the use of supplementation in the early days by parents who believe the baby isn't getting enough. During the hospital stay, frequent skin-to-skin contact is crucial. You really can't overdo it. Frequent colostrum or milk removal, hand expression seems to work best. Now, a quick note, for parents who are pumping for their premature infant or having trouble extracting an appropriate amount, utilization of the other senses can help with the milk ejection reflex. A study noted an improved output when the parent was looking at pictures of the baby and or listening to the baby's cry or coos, as well as smelling their t-shirt or blanket from the day before. Other anticipatory guidance includes normal newborn circadian rhythms, visuals of the infant's stomach, and the nominal nutritional requirements in those early days, realistic expectations, alternative supplementation techniques if they are required, and of course, close follow-up. Okay, Sekeita, any other questions from this section before I move on to?
Yeah, I think that, again, our fabulous IBCLCs have been doing a great job. Yes, so nope, please do continue.
Okay, that's great. Okay, good. So give me just 1 second. Let me navigate there. And now we're going to talk about research. And we're only going to spend just a moment on research, just to review some of the basics. So the dependent variable is what the independent variable acted upon. For example, in a study of breast pumps, the volume of milk obtained when using several types of pumps was compared. The volume of milk is the dependent variable. The type of pump is the independent variable. Now consider what we know about the effectiveness of pumping. It can be impacted by a number of factors. Therefore, there are confounding variables in this example, such as potentially the privacy of the place in which the parent is pumping. That might lower the amount they're able to extract, or the time of day could be a confounding variable. And I also would like to just review some frequently used terms. The standard deviation is a measure of how spread out the numbers are. So 68% will fall into the first standard deviation, as shown by the green on the slide. 95% will fall into the first and second standard deviation, which is that light blue on the slide. And 99.7 will fall into the first, second, and third standard deviation, as indicated by the purple. There's only going to be a few in that fourth standard deviation. So statistical significance of a study is the level of certainty in the results of a study. If we want to be 99% confident of our results, we set the significance level at 0.01. If we want to be 95% confident in our results, we set the significance level at 0.05, and that is where most medical research is. Now, there is bias. There are different types of bias, and it can influence the research. For example, a piece of research which looks at the effectiveness of a breast pump, specifically the frequency of the number of cycles per minute. You note the university who supported the research is funded by a specific breast pump company. The researcher whose university receives funding from that pump company could be biased in their study design and/or the interpretation of the results. Informed consent is when subjects need to be informed about their rights, equipment, or medications used, procedures, confidentiality, and how to withdraw from a study at any time, and any rewards for participation. Okay, there we go. Any other questions, Sekeita, before we go into question time?
Nope, just have at it. This is my favorite part anyway, so no, there's no questions.
This is your favorite part. Okay, good. Yes, it's mine as well. So what we're going to do is we're actually going to put up a poll. Now I'm going to read the question, and then we're going to turn the poll on because not all of the question fits into the poll. So, significant distance between breasts. So a physical presentation which may contribute to low milk supply is a significant inframammary fold, a breast cup size less than B, significant intramammary distance, or hypoplasia of the superior breast tissue. Okay, Jill, go ahead. So I know you can't see it. So what is a physical presentation which may contribute to low milk supply? Give it another 5 seconds. Okay, that's great. So most of you chose C, which is significant intramammary distance. So yes, the intramammary distance may be associated with hypoplasia. Cup size doesn't matter. Hypoplasia of the upper breast tissue does not indicate insufficient glandular tissue. Hypoplasia of the lower medial and lateral quadrants do. So yes, the majority of you did get the correct answer, which is C. Okay, great. Moving on here. A postglandular reason for insufficient milk production is A, the early introduction of hand expression, B, pacifier use, C, retained placenta, or D, previous breast biopsy with periareolar incision. Okay, this is great. Another 10 seconds. I believe you can change your answer if you like, but we're not fooling many of you here. Okay, that's great. So yes, a majority of you did choose pacifier use. So that is a postglandular reason for insufficient milk production. The early introduction of hand expression didn't fool any of you with that one. Retained placenta is actually not a postglandular reason for insufficient milk production. And previous breast biopsy with periareolar incision is actually a glandular reason why. Okay, moving on to the next one. While reviewing your postpartum patient's chart, you see they received Pitocin and Methergin after a vaginal delivery. You know this patient most likely A, experienced a normal blood loss, B, experienced excessive blood loss, C, gave birth to multiples, D, will not be able to breastfeed. Okay, go. So what do you know about a patient who received both Pitocin and Methergin? I would attempt to say that word, but I usually don't do well when I do it. Excellent. Seems that once again, we have not fooled you. Okay, great. So the majority of you did choose experiences an excessive blood loss, which is true. The first line medication in the management of excessive blood loss during the 3rd and 4th stages of labor is Pitocin. If the bleeding does not decrease, a second medication is indicated. Providers may choose among several second line medications, including Methergin. A is not correct because the management of normal blood loss does not require 2 medications. C is not correct because the delivery of twins does not require 2 medications. And D is incorrect because excessive blood loss does not necessarily mean breastfeeding will be unsuccessful. So we don't want to just automatically jump to Sheehan's. Okay, good. So on to the next one. Leela, lactation consultant, did a study in her hospital. Families were randomly placed into 2 groups. One group received an intervention and the other received the standard postpartum care. What type of research is this? Quantitative, qualitative, historical, or epidemiological? Okay, Jill, there we go. Study in their hospital, families placed into two groups. One group received an intervention and the other received the standard postpartum care. What type of research is this? Quantitative, qualitative, historical, or epidemiological? This one's a little tricky, but go ahead and close it, Jill. So yes, the correct answer is quantitative. So it's based on the actual data. So this is a quantitative study. So now we're going to go back to the next question. And here, Lilo, lactation consultant, did a study. She's a busy person at her hospital, where she surveyed the parents about their satisfaction with breastfeeding and what sort of problems they encountered. What type of research is this? Quantitative, qualitative, historical, or epidemiological? Okay, go. So what sort of problems they encountered? Quantitative, qualitative, historical, or epidemiological? And I think the previous question helped with the answer of this question. Okay, Jill, that's good. So yes, the correct answer is qualitative. Okay, great. Going on to the next question. Iron levels are low in breast milk. What recommendation should parents be given? A, supplement with iron drops until the baby begins solid foods fortified with iron. B, breastfeed, no supplementation needed. C, breastfeed and supplement at 6 months with iron fortified foods. D, increase the amount of iron in your diet to increase the amount of iron in your breast milk. Okay, go. So remember, this is iron. So what are we going to do? What should parents be? What should you recommend to parents? So some of the answers are, I think this one may have a few good sophisticated distractors, which is great. It's a good test to flex your muscles a bit. Okay, great. Go ahead and close it, Jill. So the correct answer is C, breastfeed and supplement at 6 months with iron fortified foods. So additional iron intake by the parent will not increase the iron levels in breast milk, even if the parent is anemic. Iron supplements taken by the parent may produce constipation in the baby. At least that's what clinically some parents have noticed. And anemia in the nursing mother has been associated with poor milk supply. So we do not begin supplementation with iron drops right from the beginning. That's not necessary. And yet at 6 months, indeed, supplementation may be needed because that is usually when the baby has exhausted their stores from birth. Okay, moving on to the next one. Now we've got vitamin D. So another supplement here. We did iron, so now vitamin D. Vitamin D levels are low in breast milk. What are the current recommendations? A, supplement the baby with vitamin D until solids are started. B, breastfeed, no supplementation needed. C, breastfeed and spend a half hour a day outdoors in the sun or in the lighter, outdoors in the light. Or D, baby should be supplemented with 400 IU of vitamin D daily. Okay, let's see. What do you think of this one? You know, it's really interesting how the answer to this question has changed over time. So if you have been around for a minute, as we say, then indeed the answer has changed over time. Okay, great. Go ahead, Jill. Close it. So the answer is D. Baby should be supplemented with vitamin D, 400 IUs of vitamin D every day. And the reason why is because indeed it's something which is a bit of a crisis as far as our vitamin D levels, both in lactating people as well as in infants, is low. And so you want to be specific about how much you're supplementing the baby. As far as spending time outside, while that may be something which is suggested in your community, the research doesn't identify where on the planet the baby is as far as going outside. Plus, you also want to be careful and not risk the baby getting too much sun and getting a sunburn. Therefore, it's better to be very specific about this and to supplement babies with 400 IUs of vitamin D every day. Okay, great. Going on to the next slide. Now let's not open the poll yet. Let's just hold off a second. So how old is this baby? All right. So a couple of things that I just want to point out is one is that this baby here. So take a look carefully. Notice that the baby has a social smile. The baby lifts their head about 45 degrees. Baby can hold the head up for a few seconds and visually searches to locate familiar faces or sound. So, is this baby A, 2 weeks old, B, 4 months old, C, 2 months old, or D, 8 months old? Go ahead. So this one is a little trickier. You may notice those fat pads on that baby. And some people will ask, is this indicative of what may be on the exam? They won't give you hints, that I do know. But yes, this one is definitely a little trickier. Now notice how high this baby is able to hold their head. Okay, go ahead and close it, Jill. How high this baby is able to hold their head, and notice how their fists are nice and tight. And so this baby is actually 2 months old. And so she's lying on her abdomen, and actually at 2 months, this parent actually came down to where the baby was and took the picture very quickly. Very proud that the baby was able to hold up their head already. But 2 months is an age where a baby can lift up, but they just don't sustain the pose for very long. Okay, moving on to the next one. Which of the following viruses is most likely to be transmitted to the infant through breast milk from an infected parent? A, hepatitis C, B, herpes simplex virus, C, varicella zoster virus, or D, cytomegalovirus? Okay, go ahead and choose. Which one is most likely to be transmitted through breast milk? I've got another few seconds left. We'll leave it open. Got to make a decision. Okay, great, Jill, thanks. So the correct answer is D. Cytomegalovirus transmission from parent to infant occurs about 60 to 70% of breastfeeding dyads where the breastfeeding parent is infected with CMV. However, healthy infants who acquire the infection in this manner are almost always asymptomatic, and breastfeeding should be encouraged. Premature infants and immunosuppressed infants are at higher risk of complications from CMV infection, and there is debate about whether the infant should receive CMV positive breast milk. Herpes simplex virus and hepatitis C are unlikely to be transmitted via breast milk. Varicella zoster virus causes chickenpox and zoster. Infected parents should be encouraged to breastfeed. The infant should be protected from direct contact with the skin lesions. And I also know that there's a question with the varicella zoster virus about when the parent actually showed the pustules, when the pustules actually formed. If it happens during that perinatal period, a day or two prior to delivery and or a day or two after delivery, it's more dangerous. And so indeed, there are different precautions which need to take place in that small window. Okay, going on to the next question. Here we have Tyler. Tyler is a vegan. Their diet is vegan. What would you suggest to ensure adequate nutrition for Tyler and their baby? Protein from beans and rice. B, minerals such as magnesium and selenium from grains. C, folate from dark green leafy vegetables, or D, B12 from fortified foods or supplements? Okay, which one do you think this is? Tyler is a vegan, or they eat a vegan diet. It's a better way to say it. So do they need minerals such as magnesium and selenium, folate, or B12? What is the thing in which we want to make sure that they receive enough of? Okay, another 5 seconds, leave it open. Okay, great. So yes, the correct answer is D, B12 from fortified foods or supplement. So a person who has a vegan diet, they do not ingest any animal products, and that is the only dietary source of vitamin B12. So to avoid this deficiency, vegan nursing parents and those who consume very little animal protein need to take steps to ensure they receive vitamin B12 either from foods which are enriched, or take regular B12 supplements. And again, it's important for that parent also to follow up with a nutritionist and/or their healthcare provider. Okay, great. The primary reason for providing human milk to premature infants is to improve bonding between the breastfeeding and chest feeding parent and baby, assure continued breastfeeding or chest feeding after discharge, significantly decrease necrotizing enterocolitis, or D, improve neurologic outcomes. Okay, so with this question, what do you think is the primary reason for supplying breast milk or human milk to premature infants? Bonding, continuation of breastfeeding, chest feeding, preventing necrotizing enterocolitis, also known as NEC, or improve neurologic outcomes? Another 5 seconds. Okay, thanks. So yes, while all of these things are important, the most important, or the primary reason, is to significantly decrease necrotizing enterocolitis. Great, and most of you got that one right, so yay. A couple left, just 2 left. A potential risk of skin-to-skin care in newborn infants includes respiratory instability, sudden unexpected postnatal collapse, hypothermia, or sudden unexpected infant death. Okay, which is the potential risk of skin-to-skin care in newborns? Respiratory instability, SUPC, hypothermia, or SUID? Okay, great. Go ahead and close it. Thanks, Jill. And the correct answer is B, sudden unexpected postnatal collapse. So there are research parameters and toolkits, as well as checklists, which can be performed immediately after birth to ensure that the baby is safe and the parent is safe. So safe skin to skin is something which is important. Respiratory instability, actually it's the opposite. Skin to skin care in the newborns provides respiratory stability. And hypothermia, the baby will not be too cold if they're skin to skin with the parent and covered with a blanket. So it's not hypothermia. And then sudden unexpected infant death is something which is different from sudden unexpected postnatal collapse. So if this is a new concept for you, do take a few minutes and take a look at the data around SUPC. Okay, this hand technique in this image is useful for all infants, except, so take a look at the image on the slide before we start the poll. This is useful for everyone except premature infants, Down syndrome infants, neurological impairment, or infants with type 3 ankyloglossia. So which infant is not benefited by this technique? Okay, Jill. So not sure if we really fooled everyone on this one. Hopefully you know what this is a picture of. what this is known as. Don't want to give you too many more clues, might give it away. Okay, great, Jill. So the correct answer is D. So what is this position? This is known as a straddle hold. You can see the parent and the baby are chest to chest, and the baby is in an upright position. You can see that the legs are probably on either side of the parent's thigh. And so it's a straddle hold, and it's known as the dancer hand position. So you can see that you've got support by the thumb, as well as by the parent's thumb, as well as the parent's index finger on the baby's cheeks. And so the only one so premature infants can benefit from this, an infant who's been diagnosed with Down syndrome, an infant with neurologic impairment, all of those will benefit. But the infant which will not benefit from this specific position are those with type 3 ankyloglossia. And I do know that ankyloglossia and tongue tie is pretty hot in the lactation world. So I just threw that in there to see if people would pick that one. So here we go. Now, the World Health Organization guidelines for preparing powdered infant formula recommend boil the bottle and teats for 20 minutes, a rolling boil, or boil the water used for mixing for 20 minutes, also a rolling boil. Selection C is mix the measured amount of powdered formula and hot water as defined as over 70 degrees centigrade or 168 degrees or 158 degrees Fahrenheit, and store prepared bottles in the refrigerator for up to 72 hours. Okay, the World Health Organization guidelines for the preparation of powdered infant formula. What is the recommendation? So you will note that in these guidelines, several of these topics are mentioned, such as storage of formula, which is powdered infant formula, which has been reconstituted, that is in the handout, as well as what to clean, what to boil, what to sterilize, that's included in the guidance as well. Okay, great. Go ahead and close it out. So this one definitely split the crowd, and the correct answer is C. Mix the measured amount of powdered formula and hot water, and the number specifically of 70 degrees centigrade and 158 Fahrenheit is important. So yes, you do need to clean the bottles and teats. You do need to wash them, but you do not need to boil them for 20 minutes, nor do you need to boil the water that you use for mixing the powdered formula for 20 minutes. So both of those are incorrect. And as far as storing bottles of reconstituted powdered infant formula, it can only be stored in the refrigerator for 24 hours. Okay, great. So Sekeita, what do you think? Are there any questions before we go to exam day survival guide, or should we just keep going?
So I think we should keep going in the interest of time. It's 4:08, and I know that we said we would go over just a little bit, but yeah, I think I'll be speeding through. I think our IBCLCs have been rocking it out with the questions. There is one thing I do want to state before, and Angela, stay on for just a minute. This notion of the question has come up several times, will this be US based and that sort of thing? No, this is an international exam. Well aware that there may be some differences in practices based on that. Also well aware that even sometimes when the recommendations are set, even the practice don't follow. So this is an international exam. Try to think of it like that. For example, when we think about HIV in the USA, no, HIV is not recommended. However, in other parts of the world, it is. So think about it like that. The test is not designed to trip you up or anything like that. And someone else mentioned the ABM, and I do want to say that the Academy of Breastfeeding Medicine is also a global entity. They're a group of organizing physicians from all over the world. Mm-hmm. So in saying that, I just wanted to clear that up because it seemed as I was kind of skimming, I'm not able to read You know, but I think that our IBCLCs are doing a lovely job. But I did want to just state that, you know, no, this exam is not US based. I think as educators, when you grow up and you learn under USA, right? You know, we try to do our best to kind of learn other places. So I want to just say, pardon us if it feels like it's too USA centered, but in all honesty, it will be. Think about whatever the recommendations are based on a global notion. And so I hope that helps, and I hope that also alleviates some of the fears or anxieties about that.
Thank you so much, Sekeita.
Yeah.
Okay, great. So exam survival guide.
Okay. So, all right, put your hands down. So here's the thing. If you were writing, whatever you're doing, just stop for a minute. I know we just went through so much information. I am mindful that our audience are not just all from a medical background. We have an audience that some people may be engineering and want to become an IBCLC, right? And so sometimes when you're processing different information, it can become overwhelming. And based on the amount of questions that I was seeing, I'm feeling like some people may be overwhelmed. So before jumping into the exam day survival guide, I want you to think about the questions that Angela just had you answer in the polls. And think about those areas where you're not so strong in. You want to note that because we do a 30-day and we do a 90-day. So I just want you to keep those things in mind, so that those are areas that you're like, yep, I need to focus a little bit more on that. The stuff that you knew hands down, that's water under the bridge. You don't need to do it. So take a cleansing breath, because that was a lot. So just take it in and let it out. All right. So we're going to talk about exam survival. And I'm going to try to do my best to be timely, but I am aware of the time and I might speak a little fast. So forgive me. So we're at this point where you're preparing, you're on the home stretch. The passion, the dedication, and the endurance is so necessary in these next coming up days, because you know there are some people who's going to sit the exam the first day it goes live, and then there's others that's going to have some leeway. But you do that same passion and dedication that brought you into the field, use that to kind of thrive and push yourself. When you arrive at the exam on exam day, walk in like, I got this. Be confident in the things that you know. And of course, we don't know everything. Of course, I mean, I don't know not one person I've taken the exam twice, that's gotten like all of them. Some right. So keep those things in mind. And pat yourself on the back. So I talked about staying connected to your passion, celebrate your dedication, and be proud of your endurance. It's important to trust yourself in your preparation, and I'm going to put a caveat there. That's if you have been preparing. If today is your first day in like really starting to study, I would say be intentional about the rest of the days that you have. Try to plan and try to govern your study according to. Sometimes we think that, oh, I've passed this test, or I do well in tests. Remember that this test again is focused on from a global aspect. So I'll end there in the interest of time, but yeah, just prepare. All right, I talked about breathing deeply. The breath work that some people do is extremely and critically important. But one of the things I want to say is sometimes when we're anxious and sometimes when we're trying to process a lot of things, we breath hold. And when we hold our breath, that then decreases the oxygen to our brain. So it's not like we're just saying breathe as some really like fluffy stuff. Yes, you have to remember to breathe deeply to get that oxygen to continue to flow to your brain, because sometimes when we get stuck, we're like, and that can also cause like some brain fog a little bit sometimes. So just remember, this is not something that I'm saying just breathe just for the heck of it, but when you get stuck or if your breath hold a lot, remember to breathe during the exam. So before your exam date, there's certain things you have to know. You have to know, you got to have your confirmation number from your email. You should know what to expect. If you're doing the exam by proctoring in video, you should really understand what's at stake when you're doing it, what the system requirements are. You should also know that you can't test on the tablet, and the Surface Pro is considered a tablet. If you're not sure whether or not your device qualifies as appropriate, then you should really be on the website if you're going to do it live proctoring. If you're doing it live proctoring, make sure you have a stable internet connection. And also, there's going to be several security checks. There are some growing pains and have been some growing pains since the pandemic hit and live proctoring became a thing that folks had to really do the exam, you know, at home. So just make sure you know the security checks, you know what to expect. What about breaks? Do you know what happens during breaks? So I'm not going to kind of spoon feed you, because I think that when you read it, you will know it and you will be successful because you'll have the information. You're more likely to remember it. There are some computer system requirements that are necessary. So when you think about your computer, I already talked about you can't use a tablet. You have to use a laptop or desktop. The other thing to note is that dual monitoring configurations are not permitted. So one of the checks will be scanning the entire room to make sure that you don't have anything. I'm sorry, and I also mentioned, I mentioned the Surface Pro, but also iPads are not considered appropriate for taking the test. So your web camera, you'll need a movable webcam for checking the process. A webcam in a laptop is accessible as long as you're able to move your laptop around to show the entire room. You may not have more than one webcam that's being used. Power source, make sure before you even get started that your laptop is plugged in. I don't know if anybody has a computer like mine, but mine is on the last leg and it alerts battery or low charge and then it just goes out. You don't want that to happen, so make sure. If you are not hardwired in, that's another recommendation. Also know your internet speed, where if you're working, and this is all from doing just live proctoring, of course. So know all of these things, and do you know what to do? So for example, if you're taking the test, do you know what to do if you start to have technical difficulties? If not, that's something also to look into. So these are things that you want to do prior to going in, and you want to make sure you make the proper preparation so that you're all set up before test date. For those that are testing in test places, and I can't speak for all test places across the world, but I will say that for the most part, candidates have been required to wear a mask or face covering for the entire time that they're at the test center. So check your test center, make sure you know what you know, if you have to mask, if you don't, as well as as well as complying with any other federal or local requirements that are in place at the time of the testing that you're going to do. We know that things have been so fluid, so at any moment things are subject to change. So as things change, also make sure you do a double check and swing back if necessary. You want to do a system readiness check before you do that also. So just making sure that you test all of your systems. All right, so taking your exam temperature. This is a thing that I say is to think back about any test that you've done before and what's worked for you. When were you successful and when were you not successful, right? So if you feel great and have a good handle on everything and you feel like, yep, I think I did pretty good. I am doing these questions. I've been studying for this amount of time. Stick with it. But if you're nervous and know that you will be nervous, take some steps to help you succeed. And that means thinking back, when are the other times, when have there been other times that you've had to sit for a big exam and your nerves were like this? What did you do? How were you successful? And trying to channel those things and incorporate them into today and now. The night before the exam, you don't try to cram, but I love this quote. This was a quote that I saw recently, and I'm just sharing it with everybody, but it says, many students cannot pass their exam because they fail to sacrifice the minimum capital of time and money. So, and I know that the tail end of that is money. Sometimes we do have to spend extra to kind of for knowledge, and other times we don't have it, which sometimes can be a barrier. But I do want to say the capital of time. We have 30 days and we're counting down, right? So use that capital of time to help build your success. So before the exam, make sure if you are taking your exam at home by live proctoring, please plan to be alone, no pets or people. That's one of the automatic terminations and disqualifications. Even if your kid busts through the door, there's just no exception. So you also want to be in an area where the internet is the strongest and you have good lighting, and suggest that everyone stays off the internet. No streaming, no social media, none of that. And consider hardwiring again to your Ethernet cable so that if there's any disruptions in the system, you're already hardwired in. And you also want to make sure you just have quiet time. This is a timed exam, and so you want to make sure that everything is all set the night before. You don't want to get up scrambling to try to figure out how you're going to be alone. Where's the greatest light? None of that, because that also will produce some anxiety, and unnecessary anxiety could have been prevented the night before. So before the exam day, some people make a playlist to build your confidence and put a smile on your face. Music works for me. Podcasts, not so much, but some people find podcasts that make you laugh, or there's meditation apps, or just simply writing yourself notes on the refrigerator the night before or wherever, in the bathroom mirror, and place those notes of confidence. And again, sometimes it's just about building yourself up in the presence of anxiety, and that kind of decreases it, because then you go in with this boost of confidence, which could impact test taking for the best, for the better. I talked about that. We can just go to the next slide because we are way beyond time. All right, so this is important. Today is the day. Eat something that your body is used to. Don't go get all exotic and all of that. Eat whatever your body has been used to. You don't want to be sick or anything like that. Comfortable clothes, especially if you are going to be going to a testing site. There's no need to dress to impress. Trust your preparation, do your best, and just know that if you've done the things that are necessary, you are ready. The test will be a total of 175 questions. Remember, this is an international exam. So for those of us in the US, this is not US specific. When you think about expressing milk, you want to, for example, think about hand expressing over pumping, that sort of thing. So 175 total questions, 2 parts. There's multiple choice, and then the other second part will be images. The test is 4 hours in duration, 30 minutes extra if if the exam is not in your primary language. And that has to be prearranged. So if that's something that needs to be prearranged, go ahead and make sure you have that in place. Each question has only one correct answer. There are no penalties for a wrong answer. So it's to your advantage to answer all questions. And I know sometimes there seems like there's always two, the answers could be, there's two answers there. Choose the best answer. Next question, next slide, please. All right, so read all the questions slowly. I know this happens to me. The world is sped up so fast, and sometimes you want to skim over things. Try not to skim over the question. Read every single word. Think about what is the first thing you would do. Eliminate obvious wrong answers, and then watch out for negative STEM questions. Hopefully you won't have too many of those, but sometimes they do creep up. And when I talk about negative STEM questions, what I mean is, which is not, what is least likely, or everything except. So those are the types of things you want to really pay attention to, because sometimes if you misread the question, you can get it wrong when you absolutely know the answer already. Again, I've already talked about this being an international exam, and I've talked about breathing. Next slide, please. All right, work at a comfortable pace. Again, it is timed. In this test, you'll be able to mark those that you aren't so sure about and then go back to them. So make your best choice and then move forward. Your first impressions is usually the correct answer. Try to resist the urge to second guess yourself. So if you're unless you get like this whole thing like, I know that's wrong, then change it. But usually your first impression is the correct. It might also be counterproductive to review answers and make changes, especially if you're struggling to get through the test. So don't read more into the situation. The people that have written the test have given you exactly what they want you to know in order to answer the question, because there's always exceptions to the rule. Like they give you a question, you're like, well, what is this? If they didn't give you that doesn't matter. Don't read into the question, answer it based off the information that's given. All right, immediate termination. This is what I was talking about here. You cannot leave the examination workplace. The only time permitted for a break is between parts 1 and 2. And if you have to move and you have to take a break, you have to alert the proctor before moving away from your web camera. During the break and after finalizing the exam, make sure again you read all of the things that are necessary. Leaving the view of a web camera without acknowledgement from the proctor, so the proctor has to acknowledge you, including your scheduled break, will result in an immediate dismissal from your exam. All right, and again, I talked about no third parties. You can't turn off the lighting or computer audio. You can't do any of that. Moving from original testing location or speaking to and receiving aid from someone else is strictly prohibited. All right. Once you are done, sometimes we get done early, sometimes we get done late, but once you are done, you are done. Some people are like, yes, I'm done. I burned that up. Like, okay, I don't ever want to see a book again for a little bit. And then some people are like, yep, I checked that off my list. And then those that's walking into the test real confident are like, I got this, I'm done. Whatever event, you're done, right? And then comes the stressing about when the results are going to be there. Try not to do that. Try to kind of take the rest of that day and wind down. Again, because the excessive cortisol level, like these are things that are really happening. So take some time to kind of just wind down. Think about your next steps. Think about when you're going to become an IBCLC. Think about where you're going to practice. Think about the networking, all those things. And then try to not keep going and refreshing the IBLCE website to see if the test results are up, because I know we do that. So with that being said, I am going to invite Angela back. I don't know if there's any other questions that we may be able to answer. Recognizing that we are at time. I was hoping to be done by 4:30. I made it to 4:29, so yes. You're muted, Angela.
I just realized, because I just said, don't be too excited yet, Sekeita. So there are a few questions. People are asking, about the structure of the exam. We actually did a webinar a couple of months ago, and it's called the 90 days to the exam. And so that goes over the detailed content outline. It goes over the types of questions. Sekeita, you just did that briefly. And so, yes, all of those things, what exactly is going to be on the exam. As Sekeita just said, there is a non-disclosure, and so people don't walk out of the exam and then tell us what's going to be on the exam, because we don't know. And the exam is changed from year to year, and from beginning, from the March, April administration to the September, October administration. So the exam does change, and so you can't make any sort of assumptions. The detailed content outline actually is what you need to know for the exam. As far as cranial nerves, as far as lab numbers, you do need to know what is normal and what is not. And so, for example, if I said that, Sekeita, this baby is 12 hours old and has a bilirubin of, 14.7, what you need to know whether or not that is something which is of a concern and something which isn't. Someone else is asking a question about what is a passing grade. IBLCE also changes that from year to year. And we have a blog post which talks about how IBLCE grades the exams, and there are some questions which are thrown out. And then the exam is if they do not, essentially, if they do not score psychometrically or statistically appropriately, then they are reviewed by the exam committee, and some of them will be tossed. And then the entire exam will be rescored. And so the passing rate can be anywhere from 72, 78, something like this. So it's not 100%, if that gives you any sort of reassurance.
Yeah.
So,
Thanks,
Sekeita,
Angela.
what
I
else
do
did
want
you
to
do?
address one thing, and we may have said this, but it's been a long day. But I do want to say that I think, Angela, you did say that it's practice oriented. So try to know how you would practice. What would you do? How are you translating the knowledge, and what would you do in a clinical situation? So in some questions, you will be given a situation. Most of the questions, and you're going to have to think through. Okay, and you're going to have to synthesize and put the knowledge together. So like how we just do section by section, you're going to be put into a situation and have to answer that question. So think about the test like that.
That's a good point. Thanks, Sekeita. I wanted to put this slide up to help people to remember their why. This is one of your slides, Sekeita, and I just adore it.
I know. I forgot about this slide, but I do. I say remember your why. Everyone has their personal story as to why they're doing this. And some of the stories, if you talk about storytelling, which is data, by the way, it actually fuels us and is what keeps us going in this field. So remember your why the day of the test. And that also will be a confidence booster and also strength. You get strength from remembering why we got into this.
This is true. One quick, let's talk about the HIV.
Yes.
If a parent is HIV in different parts of the world, what would you like to address that?
I'm just going to say that it's global. When you think about globally, I think when we talk about HIV, in higher resource countries, most folks say no. But know that HIV positive people across the world are still breastfeeding. And, there is new literature that's coming out that's talking about, the immune status of the parent as it relates to the recommendations of breastfeeding, even in the US here. So just know that the questions regarding HIV won't be specific to a continent. It will be a global general question.
Correct. And as far as HIV is concerned, remember that not only does it have to do with where not only does it depend on which country, but more importantly, it has a risk benefit, question.
Yeah.
And whether or not formula is available, whether it's safe, whether it is feasible, and access to formula. And so there are many questions which are involved with HIV. And as with several questions you will find on the IBLCE exam, it's not a black and a white. And also, if you say to yourself, well, gee, I knew a baby who blah, 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 chances are you're going down that rabbit hole. And so come back and think about what the World Health Organization would say, some of the data from the American Academy of Pediatrics. Think about the overall, the aggregates, as opposed to the one-offs. So, good. Is there anything else that I missed today?
No, I would just add ABM, because I know ABM is a global, AAP is more US centric. So I would add ABM also to increase your knowledge. And also ABM is what you want to have in your back pocket always going forth in practice, to just become familiar with the different protocols. Because what the ABM does is they do synthesize the data and look at the levels of evidence and make their recommendations. And they might change, they don't change their protocols on a cycle per se. If there's some evidence that comes out that's like, we need to change this right now, it usually gets revised.
That's right.
The
protocols, you can find them on bfmed.org, bfmed.org. It's the Academy of Breastfeeding Medicine. So thank you very much for your time today. Yes. I really do appreciate it. I really appreciate all the love that y'all are giving us as well in the question box. We do apologize for going a little bit long, but we know how important this is. So thank you very much for your participation today. You will receive the recording. If you missed anything, if we talked too fast or stumbled over our words a little bit, the recording will be there, and so you can review it. So
absolutely. Enjoy your day. Bye-bye.
Thanks, everyone. Bye-bye.